So now I would like to invite Dr. Rajesh FOGLA, who is an international pioneer in especially the corneal surgeries and especially the early adapter to the clear technology, which is the new frontier in lenticular extraction from Zima. So we would like to learn from Dr. Fogla why he believes
Thank
that
you.
the clear is the way to go forward. Thank you.
Before I start my talk in terms of the loss of one line, in any refractive data analysis when you perform, we look at the preoperative corrected distance visual acuity. So you will have patients who read 6 by 4, 6 by 5 as well. Now post-operatively, if this patient from 6 by 4 goes to 6 by 5, or somebody 6 by 5 becomes 6 by 6, we still call it loss of one line of visual acuity. But when you look at percentage of patients seeing 20/20 or better, you get very good results. So the interpretation of loss of one line sometimes has to be taken in the context of what was the. Yeah, it's still a loss of one line, but what I'm saying is there are other factors also that come into play. So I don't think there is any refractive procedure in the world that will not have this loss of one line. So basically we look at. Yes. So I'll talk about my experience with this lenticule extraction with the Z8 platform. I've been doing it for the past 1 year. Now, CLEAR stands for corneal lenticule extraction for advanced refractive correction. It's approved for -5 to -10 in the cylinder from 0 to 5 diopters. It has a very short pulse duration of 200 to 500 femtosecond. The repetition rate goes up to 20 megahertz. The pulse energy, although it says less than 100 nanojoules, when I speak to the engineers for the CLEAR procedure, the pulse energy ranges between 20 to 40 nanojoules. And the spots are overlapping. That's why it takes a little longer compared to the other laser systems. But the end result is that it leaves behind a very smooth interface. And that we have seen when we have been doing the LASIK procedure with the Zima platform, and we find that the flaps are pretty similar to what you see with the microkeratome. Now, because of this lower energy, you get negligible inflammation in the stroma, and that results in faster visual recovery. In terms of incision, Maipal did mention that the laser gives you the ability to customize your incision. You can make 1 or 2 incisions in the initial part when you're starting with the laser, and these incisions can have the endpoint going into the anterior plane or the posterior plane. As you know, somebody, when they start with the lenticule extraction, the main problem is identifying the correct plane. Sometimes you go into the posterior plane, but you find it difficult to find the anterior. So here, having the 2 incisions makes it a little bit easier and added safety. And the other thing is that the Zima laser also has the intraoperative OCT. So once you have docked into position, you can always run the OCT scan and see where exactly your incision is going to be, whether it's within the applanated area or not. So, and intraoperatively, if you did have a complication, you can always use the OCT to go back and recover from that. The other advantage that the laser has is that the delivery has an articulated arm, the handpiece. So you can position the laser on either side of the patient. You can bring the arm. So even if somebody has a deep set eye or an uncooperative patient, it's easier to apply the handpiece on the eye. It's not very intimidating like a huge laser, the thing moving onto your eye. So here, that way we find that it's very easy on the patients. Centration, it gives you the ability to shift the centration after docking. It has automated cyclotorsion control. You can, so all these customization that you can do, as you will see in this, that when we are planning the treatment, we enter the mean SIMK, the Q value at the 8 millimeter zone, put in the pachymetry, and real time you see what is the residual stroma, adjust the sphere cylinder, and if you do have some nomogram adjustments in terms of the target refraction, you can perform that. You go on to the patient side. The suction ring is 9.5, so the chances of loss of suction is almost 0. I have never had a suction loss either in the LASIK or the CLEAR procedure over the past 12 years that we have been using it. It does the same thing. It does the anterior cut, and then you have the posterior cut happening, and then you see the incision. I prefer a 2 millimeter incision now, so I don't make 2 incisions. And then on the patient's eye, you can see that's very nice. And as Maipal also pointed out, that you need to optimize the energy. Right now, we are working with a level of something like 29 and 34, but when the laser got installed, it was pretty high at about, working at about 45 uh, nanojoules energy. So you can find the anterior plane, then you dissect the posterior plane. So pretty much all the lenticule extractions are quite good in this, whether you look at the smile, you look at the silk, or look at the smart side, all of them, you will see that the ability to create the anterior posterior plane and extract the lenticule is pretty good. End of it, we just give just a gentle wash in the interface, and then that's pretty much the end of surgery. You can see post-op, this is a patient with -7. Next day, it's almost plano. That you look at the large optical zone, both for the right and left eye. The cornea looks very clear on day 1. If you look on retroillumination, especially for higher degrees of myopia, you may see a slight interface mottling just on day 1. But over a period of 1 to 3, this goes away. Sri Ganesh has a very nice paper on looking at the scatter index and then quantifying the interface irregularity. On OCT, you can see it's a very nice, smooth interface. There is no adjacent inflammation in the anterior or posterior cornea when you do this. This is, again, just to show you the kind of outcome that you get. If you look at the data available on in the literature, if you look at the SMILE data, you can see the outcome of 20/20 or better varies from as low as 37% going up to almost 100%. And if you look at the initial data of the silk procedure as well, day 1 you can see that nobody has 100% 6/6 on day 1. Here it was 46%. At 1 week it became 79%. And if you look at this paper from Shady Awad that was published last year on the outcomes of clear in about 102 eyes, you see that an unaided vision of 20/20 or better at 1 week was seen in 75% of the eye, which improved to 93% at 1 month, and 95, almost 96% at 3 months. And 50% of the eyes gained 1 line of corrected distance visual acuity. My own personal experience for patients who have 6 months follow-up or more, 56 eyes, we find that we initially restricted ourselves to myopia between 3 and 6 diopters and astigmatism less than 1 diopter. We also had similar outcome of almost 78% patients seeing 20/20 on day 1, improving to almost 90% in 1 week, and at 6 months it improved to up to 96.4%. The only complication that we saw was cap edge tear when we started making 100 micron caps, and ever since we have gone back to making 130 microns. Zimmer has this new software called the Flow Suite that will integrate the Galilei or the Sirius with the laser machine. So you will have markerless cyclotorsion control. You can do your treatment planning even before going to the laser. You can do it for the right and left eye. So that basically helps with the workflow. And they're also coming out with their solid state laser, the Aquaris, and that will also add the Excimer platform to them. So in conclusion, the learning curve for clear has been fairly smooth for somebody who has not done a lenticle extraction, primarily doing LASIK. We realize that the optimal laser energy is required for predictable outcomes, and that's pretty true for any femtolaser system. Gentle dissection and consistent technique of lenticule removal is important in the learning curve, because if you use sharper instruments, sometimes you create false plane, or you can leave behind a retained lenticule if you start off with very low degrees of myopia. And always prime your patient with the possible delayed recovery or enhancement. Although most studies have shown that patients achieve very good visual acuity on day 1, but if you compare with customized LASIK, I think LASIK still scores that the day 1 wow factor with the vision, the sharpness that you get is much better with LASIK. But if you go back at 1 month or 3 months, I think they are quite comparable. Thank you. Thank you for a patient hearing.
Thank you, Dr. Fogla. Dr. Sheetal has also used this clear technology, so she has one question for you.
Great presentation,
yes,
sir.
tell me.
Sometimes I find that the centration that we do on the monitor is a bit confusing. How do you really center? Because it has to be done manually, right? So, like in your video also, which you showed, it was looking quite off, and then you kind of centered it on the, what are the reference marks that you center it on? Is it on the pupil or the limbus? How
No,
the
when we
lenticle
do
should
the
be centered?
treatment, we try to put it on the line of sight.
Line
Now,
of sight.
when you, so that's why I think I do a double docking system. I don't go as a single dock, because then what happens is if your eyeball moves a little up or down, so when you put your suction ring perfectly at the limbus, so that achieves corneal centration. And then when you're applying that also, you have a light or a fixation light the patient looks at. So that ensures that you know where your line of sight is, especially patients who have larger angle kappa. Otherwise, what will happen is you will try to center it on the pupil, and then you can have a displaced, although we use much larger zones of 6.5, so even if there is a slight displacement, it still compensates, but ideally you would want to have it exactly on the line of sight. We make slight adjustments because sometimes the pupils are not exactly in the center and you find one edge is coming very close to the limbus, then you try to move it a little bit to the center of the cornea.
Since it's a flat dot,
Yes.
very high pressure, sometimes there's a trip. So what we do is to, under the operating microscope, ask the patient to look at the light and make a spot there, and then at the time of docking, center it on that. It
Yeah,
seems to
I've
work
seen
well
that. I've
both
been
with
to your
silk as
center
well
and
as-
I've seen that you do the double docking. You have a
Yes.
small flashlight
Correct.
that you put on
on the-
ask the patient to look at, and then you apply. So that's pretty good. I think that's what we do. And this becomes more important if you start reducing the zone size. You know, you want to treating a high myopia and you find that you are not leaving behind residual bed significantly and you move on to 5.5 or 5, then centration becomes very critical because
yes,
if you
sir.
don't center it very well, and this patient has a mesopic pupil that's larger, then he's going to have more of the symptoms nighttime.
I use a standard optical zone of 6.7 or
Yeah,
sometimes
I-
6.8 with the Zimmer platform, because I'm never like 100% sure whether it's centering properly or not, because little bit decentration here and there because of the flat interface, as you said. No, so yes, ma'am. Yeah, ma'am, of course, yeah. If the corneal thickness is good and all, yeah.
Yeah. So mine is between
Wherever
6 and
it is
6.5.
possible,
so
I like to use a
sometimes
6.8.
6.2,
These
6.3.
high
So I look at the
myopes
residual
would
bed and just
require a-
adjust.
Yeah, high
bigger
myopes, of
zone.
course, we reduce, then we have to be more
Yeah,
cautious
because they're
about the
ones where you
centration, yes,
actually
ma'am.
want a big zone,
Yes, ma'am.
and they also have bigger pupils. So.
Okay.
Thank you.
Thank you, Dr. Fogla.